I want to introduce our second speaker, David Richardson from Southern California, who is a general ophthalmologist, very accomplished cataract and refractive surgeon, and who has, I'm going to say, fallen in love with canaloplasty. That is not too strong a statement. He's going to share with you a different perspective today, really looking at this, I'm going to say, how redefining how we in the field even think about that person sitting across from us who has glaucoma or ocular hypertension. Is that fair? Excellent. David, come on, take it away.
So you just heard from Dr. Thomas John a nice presentation that confirms in his early experience what we've already known through the published peer-reviewed literature. Okay, and that's always encouraging to have an individual give a presentation showing that even in the early learning curve, which is something that we've heard is very difficult with canaloplasty, that his results are as good, and somebody even commented better, than the published results. We hear presentations quite frequently that give what I call the surgeon's perspective, focusing on the pressures, on the disease. This is what we're trained in. And I'm going to take us through a slightly different perspective, one that reminds us of why we're here, why we're doing that, and that is to focus on the patient sitting in the chair with us. So if you could go ahead, thanks. So first of all, disclosure, I am a consultant to iScience. My love of this procedure, as Sharif suggested, it actually predated my consulting arrangement with iScience. So although I do admit to be unabashedly biased toward canaloplasty, I hope that by the end of this presentation you won't feel that there's been a conflict of interest. Next. So I'm going to argue today that glaucoma is a lifestyle disease. And that may sound a little odd. Most of us think of lifestyle diseases in terms of refractive IOLs. It's a lifestyle, whether you wear glasses or contact lenses. But glaucoma doesn't traditionally bring forth the idea that it's a lifestyle disease. I mean, this is real pathology, or so we're taught. So just going to throw it out. What is it that we're treating in glaucoma?
Prevention of permanent loss.
Okay, so I heard pressure, prevention of permanent loss. Okay, I like that. Or fear of loss, okay? Whose fear? Whose fear? It's our fear, right? So what do we do in order to treat that pressure or prevent future loss? What are some of the treatment options? Laser surgery, drops, okay? So we're taking a disease, glaucoma, which in many respects is similar to diabetes, high blood pressure. What does it share with those diseases? What it shares is that it's symptom-free. When patients come to us, okay, they are without symptoms, assuming that it's open-angle glaucoma. Okay? And what we do, which is what our colleagues in primary care do with diabetes and high blood pressure, is we take a symptom-free patient, and what do? We give them symptoms. Okay. So next, please. So this is what we think of in terms of glaucoma. We're trying to protect our patients from loss of vision. But in doing so, we create a lifestyle disease. Next, please. So what are some of the things, just to briefly go through, that we do that impact our patients' life? Well, first of all, glaucoma drops are expensive. Okay? In my area in Los Angeles, the glaucoma drops can easily be $80 to $100 a month. And believe it or not, sometimes that's even the generic. Okay? Generics are available for some drops. Certainly they've been available for the beta blockers. We now have generic Cosopt. Okay? Anyone care to comment on their experience with generic Cosopt? Have any of you noticed any differences between generics? Well, I don't know whether all generics are pretty much the same in terms of, what area you have access to. But in my area, we have access to two different generics, High Tech and Prasco. And as far as I can tell, Prasco is in fact a rebranded COSOPT. Never seen any change in pressure moving from COSOPT to Prasco. But I can tell you, without having that patient pull out their bottle, whether they've been switched to high-tech. Because high-tech works about as well as artificial tears in my practice. Latanoprost is available, but in my area, even though it seems to work well, it's almost as expensive as the brand. So let's assume for a moment that you've got, as your patient, sitting in front of you, Bill Gates. And Bill Gates says to you, I don't care about cost. Cost is, you give me a drop that costs $4 million. If it works, I'm going to pay for it. Okay? Well, even with cost not being an issue, there are other significant factors. Okay? There's cosmetic effects. We all love to tell our patients about the long lashes of Lumigan and Zalatan. Hey, our patients even pay for it under the name Latisse. But cosmetic side effects aren't all positive. Okay? All drops give you some hyperemia or redness. In the case of prostaglandin analogs, that hyperemia may actually be a result of an inflammatory condition that's actually worsening their dry eye. So it's not just cosmetic, it could be more than that. And recently there's been evidence of a new condition called prostaglandin-associated periorbitopathy, which at first is nice. It gives people kind of a little laser facial. But as it gets worse, you can get kind of a sunken appearance, tight orbits, to the point that it can even be difficult to get an accurate measurement of their pressure. Okay. Systemic effects. Okay, we all know that beta blockers have been around forever. People take them systemically. We're told don't use them in asthma, low blood pressure, and the elderly or infirm. But for the most part, we're taught, hey, if somebody's 30 to 60 years old, otherwise okay, it's safe. Well, I thought so too, until I had a patient of mine who was 45 years old, just a couple of years older than me, no systemic problems at all. I gave him Timolol. He ended up in the emergency room. Okay, now, fortunately, I actually had the discussion with him. So he was good-natured about it, which, again, fortunately for me, less so for him. Irritation. I don't know where each of you are practicing, but in Southern California, we don't have this beautiful humid air. And my patients, the majority of them, already have ocular surface conditions, are just really bothered by it. And my primary diagnosis is actually dry eye. Secondary is glaucoma. And so when we add these drops, and we've had study after study come out over these last few years, conclusively showing that glaucoma drops do worsen the ocular surface. So when you've got patients whose ocular surface is already compromised, we, in treating glaucoma, are worsening that ocular surface. Next, please. And then, of course, allergy. We all know about bromonidine. Laser, certainly an option. And laser, for the most part, is a no harm, no foul. The problem is that most of us have access only to argon laser trabeculoplasty. And argon laser trabeculoplasty, the way it's used here in the US, tends to be less effective than the way it's used in Europe. Okay, there's a fair amount of evidence that if you do it first, you'll get an effect. But if you do it after you've been treating somebody with drops for a long time, it just doesn't seem to have as much of an effect. In my practice in the past, this was really used as a temporizing measure. SLT is something that many of us would like to have access to, but how many of us in this room can really afford a $70,000 one-trick pony? I mean, so, some can, but I can't. And most of the colleagues in my area, Los Angeles, can't either. Pretty much the only ones that have it are, busy, glaucoma-only practices and the academic centers. Okay. Then there's trabeculectomy. Okay, so this is an easy target. Trabeculectomy is something that we do to our patients, and it has significant risk. We're all aware of what the risks are. I'm not going to go over the immediate post-operative course. That's a different talk. But hypotony, and certainly if you've got a highly myopic population like I do, that's more likely to give you hypotony maculopathy and a loss of vision. And so we're not only treating our patients and putting them at risk of ocular surface conditions an irritation, but we're actually suggesting that in order to prevent future loss of vision, we put them at risk for a loss of vision now. Chronic irritation, endophthalmitis, is something that you're never out of the woods on. If you use a mitomycin C trab, okay, as long as that bleb is working and there, that patient is never out of the woods. Up to a 5% per year risk of blebitis, depending on the study that you're looking at. And then there's lifestyle limitations. Okay? If you have a bleb with a mitomycin C, nice and thin, what we think of as surgeons as a beautiful bleb. The more beautiful the bleb, the bigger the risk to the patient. They cannot perform in water sports such as snorkeling or scuba diving, jet skiing. And we might be thinking, these are glaucoma patients. They're not going to be jet skiing. Okay? You're wrong. The baby boomers are, and they want to continue to be active with their children and their grandchildren. Okay? If they're myopic, like many of my patients are, they want to continue to wear their soft contact lens. And that's not something they're going to be able to do with a small or an avascular microcystic bleb next. Shunts and tubes have their own set of issues that we're potentially exposing patients to. And I don't want to belabor the point. That's just a quick list. Next. So the question becomes this. Is this bad? I mean, putting our patients at risk of these things or exposing them to the cost of medications when we're in the economy that we're in, the side effects, the irritation, the risk of surgery, no? And I would suggest that, no, of course it's not bad. We've not been sold a bad bill of goods. We've not been mistaught. What we're doing is quite honorable. Okay? We are taking a look at the risk of glaucoma, and we're saying, your vision's fine now, but you are going to lose it in the future if you live long enough. And so we're going to make this trade for you. But the trade that we're making, and that we all have to be honest with ourselves, is we are trading future loss of vision, the potential for that loss of vision, for symptoms and risks and costs now. We are making that decision. Okay, next. So first, do no harm. We're all taught this in medical school. And I would argue that what we're doing in treating glaucoma, fits within this. Even if we don't take the Hippocratic Oath, and many of us who graduated after the 1980s stopped taking it because it wasn't politically correct. But most of us will accept the first do no harm tenet. Okay? What I would suggest is we are now developing treatment options in glaucoma that require us to reevaluate this. Are we first doing no harm with our glaucoma patients? Okay, next. This is a quote from a patient of mine. This isn't actually her picture, HIPAA issues and whatnot. She had a trab in one eye and was told that she needed a trab in the other eye. And mind you, the trab in her first eye was beautiful. It was working well. There's really nothing wrong with it. It was working as a trab's supposed to. But when she was told she needed a trab in the other eye, she told me straight out, I would rather go blind. Okay? That, to me, says that there is a disconnect between what we think our patients want and need and what they want and need. Okay? Next, please. It's also important to recognize that what we tell our patients that they need or what we think is best for our patients, it may not matter. Okay? The old days of the doctor saying, this is what you've got, this is what you need, the patient's going to do what you say, they're gone. Okay? Paternalism in medicine, it's dead. Okay? When we write an order these days, even in the hospital, when we write an order, it's not really viewed as an order even by the nurse who is employed to carry out our order. Okay? Our orders have morphed into professional suggestions. That's about as close as we're going to get with our patients. Okay? Just because we tell them to do it doesn't mean they're going to do it. And for those of you who have been in practice longer than I have, let's say 20, 30 years ago, when you wrote a prescription, the patient took the prescription, got it filled, went home, started using that propene or pilocarpine, and it was irritating to the patient. what would the patient do? Use it, right? What does the patient do now?
Calls.
If you're lucky, okay? Well, generally what happens in my practice, I tell the patient to come back in 3 to 5 weeks for that monocular trial. They come back in 3 to 5 weeks and they say, I used the drop for 2 days. It was kind of irritating, so I stopped it. And I'm sitting there with an office full of patients, right? Overbooked. Could have used the spot for somebody who really needed it. And I'm thinking, why couldn't you have just picked up the phone and had the courtesy to give me a call and tell me you were having the problem? Can't say that, of course. But so then you got to restart all over again. Patients are not going to do what you tell them to do just because you've got your MD or your DO. And then there's the issue of what I call the irritating eyes. Okay? The inserts and the internet. So even if the patient's not irritated, chances are that they're going to question your prescribing that medication. Psychodynamics is a marketing term. And you may be wondering, what is a marketing term doing in a medical talk? I mean, I don't know about you, but, well, some in this room, were actually in school when it was illegal to market or advertise your practice beyond just word of mouth. So even when I was in medical school, marketing and sales, they were just dirty words. It's definitely not talked about, not taught, they were poo-pooed. But it turns out that marketing can actually help us practice medicine. There are things that marketing is really good at, and one of those is figuring out what makes people tick in terms of how do you get people to do what you want them to do? What are their fears? What are their desires? What are their wants and needs? And looking at the baby boomers, which is the silver tsunami that is going to hit medicine, and all we hear is just how much we're all going to be impacted by this, either positively or negatively. You need to understand how this demographic thinks, in general, of course there are exceptions, in order to effectively manage your patients. The old greatest generation of patients who pretty much did what you told them to do, it's very, very different from the baby boomers. The baby boomers, at least the major segment of baby boomers, consider themselves to be ageless explorers. This was actually from a survey in the New York Times. What that means is that, they want to stay active. You can't be an explorer if you can't be active. So they're not going to want anything that's going to limit their ability to be active. Never call a baby boomer old, okay? Which means they don't want to be reminded that they're getting old. Well, when we prescribe a glaucoma drop, what are we doing to that patient every single time they put that drop in their eye? They're being reminded that they're old, because people don't get glaucoma when they're young. At least that's the perception. So every time they put that drop in, they're thinking, God, I'm getting old. No. Even more so, not only do they not want to be reminded, but they will actively ignore the consequences of advancing years. Okay? And this goes beyond just ignoring the being reminded that they're getting old. They'll ignore any disease that they associate with getting old. Okay? And again, I'll just bring this up. In my practice, at least, I see a number of people, having done canaloplasty, one of the few in my area, who come to me from other practices for their third or fourth opinion, okay, as to whether or not they really have glaucoma or need surgical treatment. Okay? And if even one of those four, be it an OD or an MD or DO, has suggested that it's not really glaucoma, God help you convincing them that it is. I've got patients that I've shown them flatlined OCTs, I've shown them clear arcuates on their visual field, and their answer to me with the visual field is, I was a little tired that day, I didn't get good sleep, eyes were feeling a little irritated. Can we redo that for the 6th time? So this is a real issue. I mean, you can ignore this, But the consequences of you ignoring, your patients ignoring their disease is going to lead neither you nor your patient to where you want to be. Next, please. So what do we do? What do we do with patients who are impatient? They want things fixed now. They're active and they don't want to give up their activity. They're quite frankly ambivalent about your suggestions and in active denial about their age. Next. Well, I'd suggest that you give them what they want. And what they want is they want to fix and they want to maintain their active lifestyle. Now the problem is that we've not really had anything in the past that will do this for them. So let me go through. Go ahead, next please. The ideal glaucoma treatment then is one that is surgical. Why is it surgical? Because surgical treatments are the closest things we have to a fix. We may never cure glaucoma. The baby boomers don't care whether it's cured. They just want it under control so they don't have to worry about it. And I use baby boomers here just because they're the demographic that's been studied so much. But we all have a bit of this in us, whether we're baby boomer, Gen Xer, greatest generation, Generation Jones. You know, this appeals to all of us. It's just most prevalent in the baby boomers. Now, of course, they want something safe. The patients want something safe. We want something safe for our patients. They want something long-lasting so that they don't have to deal with it, right? So they're not reminded of it, and few side effects, right? Next. Now, traditionally, the glaucoma surgeries have not met these criteria. In the case of bleb-related procedures, you know, there are the issues of safety and the risk of the bleb. There's the fact that if you have dysesthesia, if you have bleb-related irritation, ocular surface disease, you're constantly reminded of it. There's the fact that with any kind of glaucoma surgery like blebs, I mean, the follow-up is pretty intense. So there are these constant reminders. There are these issues that keep them from meeting the ideal needs. There is, however, a group of surgeries that's been around for decades that meets some of these needs, and that's the non-penetrating glaucoma surgeries. Surgical, okay, safe in the sense that viscocanalostomy has been around for 20 years. Dr. Stegman's used it in South Africa. Horrible rural conditions in a group, in a demographic group that does not follow up and you know, does not live in hygienic areas. I mean, it's, you know, if you've got a group of people where you expect things to fail, this is the group. And yet he and his wife bust these people in from all over the bush and follow up. And the follow-up is outstanding. It's safe, long-lasting, and few side effects in the sense that there are no bleb-related issues. Long-lasting, again, Dr. Stegman has been watching this, but there's also a recent study that came out that looked at 7-year results of phaco-viscocanalostomy, not canaloplasty yet, but viscocanalostomy. And there was a sustained reduction of 30% over a 5 to 7 year period. Okay. So next. So my suggestion is that the non-penetrating glaucoma surgeries in the past have had promise, but have not been incorporated here in the US because, one, they're technically challenging. Two, 30% is awfully good for phaco-viscocanalostomy, but viscocanalostomy itself does not compare to trabeculectomy or tubes. So they're not equivalent. And then this was the real killer. There's no CPT code. If you can't bill it, patients have to pay. It's not going to be done. Okay. So next. So the question that I'm going to raise here is, can canaloplasty change that? Can canaloplasty meet the needs of our growing glaucoma demographic while addressing the limitations of prior non-penetrating glaucoma surgeries? Next. Okay. So just a quick overview. You saw Dr. John's video, so I don't think we need to go over this in too much detail. Essentially, with canaloplasty, you create an outer flap, then an inner flap. You open up the window, you find the canal, you catheterize it, dilate it, pull the stent back through to keep it open, remove the inner flap, creating the scleral lake, place it down, watertight, no bleb, you're done. Okay, next. What makes canaloplasty possible and what takes it to that step that viscocanalostomy could not get people to is this. It's the iTrack microcatheter. Okay? This catheter has an open lumen, so you can actually inject the viscoelastic. You know, unlike there's basically a poor quality knockoff out there that does not have a lumen. It just has the light at the end of it. And you miss the benefit of the viscodilation, which we feel is critical to getting the results you want next. Suture tensioning, we're talking about how to tension the suture early on with the clinical specialists in the OR with you. If you're learning how to do canaloplasty, the clinical specialist will go over in detail how you can address the tensioning to make sure that you get this tension to keep that canal open long term. Next. So canaloplasty, yeah, clearly it's surgical. Okay, next. But what about safety? Okay. So these are 3-year results for canaloplasty compared to a separate study, which was a survey of trabeculectomy. And what you'll see here is there are some things that I was really surprised weren't in the survey for trabeculectomy. I mean, why didn't they survey early IOP elevation? I mean, I would think that would have been important. Maybe they were embarrassed about what the results would have been. But in any case, I have my doubts that trabeculectomy has only a 6.4% early rise. Hyphema. Now, one thing I'd like to say about hyphema is even though clearly canaloplasty has a smaller risk of hyphema, hyphema is not actually something that you want to avoid in canaloplasty, because a hyphema is there when you've opened up the collector channels and you get reflux back through the reversed pressure gradient. So 2 studies have now independently confirmed that a hyphema or microhyphema after canaloplasty is associated with a better surgical outcome. Okay, so listed as a complication, something that you want to see. How odd is that? Okay, so you can see these other kind of things. Of course, you're not going to get suture extrusion without having a suture. Somebody asked about that earlier. 1.3%. Very unlikely to occur, but if it does occur, you've just created a partial, goniotomy, and it's generally not an issue. Hypotony. This is so much less in patients with canaloplasty that now your highly myopic patients, your younger patients, your patients with cardiovascular disease, all of these things that put them at risk for choroidal hemorrhage or hypotony maculopathy, you've now got a surgery that you can more safely perform that would, frankly, put your coronaries at risk if you were to do a trab on them. Okay? And then, again, here we have late elevated IOP. Now, why wouldn't that be reported? That seems like a really important thing to me. But with canaloplasty, it's about 6.4%, which is consistent with the report that about 5% of the time you'll need to go on to another surgery. Well, that still means that 95% of the time your pressure is where you need it to be. These are on the same scale in terms of percentages as what's reported with cataract surgery. And again, we like to think of cataract surgery as almost always, 99%. But no, the reports are actually 94 to 97% of the time cataract surgery results in improved vision. So about 5% of the time, even cataract surgery doesn't work. So these are all published results. I just wanted to highlight a couple of things. Next.
Yeah.
Yes.
Trabeculectomy,
Yeah.
year,
Back.
lab. I don't know.
Yeah, that's a very good point. Thank you. I meant to bring that up. So trabeculectomy, yeah, there are not blebs 100% of the time. That 100% is an indication that the trabeculectomy, the goal of trabeculectomy is to have a bleb, and so it's not really a complication of trabeculectomy. And so but the interesting thing here is not that it's not the percentage of the time that the bleb is still there. I actually would be interested in seeing what the percentage of the time the bleb was there, because you'd want to see 100%, but I'm sure you don't. Again, the survey was disappointing on a number of levels, but it's the closest thing that we had here to compare. Blebs at 3 years with canaloplasty, 2.5%. Well, here's the interesting thing about that. With trabeculectomy, you have to have a bleb, as you pointed out, for the surgery to work. With canaloplasty, we call it a blebless procedure, but occasionally you do get a bleb. Now the difference is this: you're not using mitomycin C, and so the blebs that you get tend to be shallow blebs that are not at risk for blebitis because you've not created a, essentially a damage to the healing process. And you can generally continue to wear soft contact lenses and perform in water sports and things like that because there's just not that additional risk when you don't damage the natural healing response. Next. So canaloplasty is surgical. There's evidence that it's safe. Next. Does it work? Okay, I'm going to pass through this pretty quickly because Dr. John already showed the 30% reduction graph, but it is worth noting that it does seem to work very, very well in terms of getting a reduction in IOP and reducing drops. And when combined with phacoemulsification, the reduction in IOP is in the range of 40%. Now, I know there's been this kind of, it's interesting how things change. A few years ago, we were all worried about pressure spikes with cataract surgery, and what do we do with our glaucoma patients who have cataracts, and are we putting them at risk? And over the last year or so, there's good evidence that the pressure is reduced after phacoemulsification. And so now people are saying, oh, well, we can treat our glaucoma patients just with phacoemulsification. Well, it's certainly possible to bring the pressure down, but let's not get confused. That pressure reduction after phacoemulsification in the vast majority of people is a couple of points. Okay? And what the study showed was that the higher you start, the bigger the reduction. But if your patients are running in the mid to upper teens and low 20s, you're not going to see more than a couple of points, a couple millimeters of mercury reduction from phacoemulsification alone. So when you see a procedure that combines cataract surgery, that with cataract surgery results in a 40%, not 14, 40% reduction in IOP, that's the additional procedure. That's not the phacoemulsification. What's more impressive to me is that almost 90%, 88% of people who had phacocanaloplasty stopped all drops. All drops. Okay, that doesn't happen with phaco alone. Next. So I'd say it's surgical, it's safe. How about long-lasting? Okay, 3-year results. That's pretty good. I mean, I've been told by a couple of academic glaucoma specialists that the average time to failure with trabeculectomy in the community, and not in those who that's all they do is glaucoma and the academic centers, but in the community runs around 2 to 3 years, average time to failure. Well, with canaloplasty, the rate of success at 1 year was the same as the rate of success at 2 years and the same at 3 years. So the slope was essentially 0. So if you're good at 1, you're good at 2, you're good at 3. Well, hopefully we can extrapolate that out. We don't know that we can, but again, looking at the long-term viscocanalostomy studies, it certainly looks very good. Next. Few side effects. I mean, not only are there not the issues of blebs, but many of my canaloplasty patients, pure canaloplasty, not phacocanaloplasty, because they're no longer using drops after surgery, their vision actually has improved by a line or two. So not only don't they have side effects from the surgery when it succeeds the way it should and gets rid of their drops, but it's possible for them to actually experience an improvement in their quality of life. Next. But how does it compare? I mean, that's the big question, right? That's always the elephant in the room. Oh, it's trab. Nothing compares to trab. Well, does it? Ike Ahmed presented this paper at ASCRS a couple of years ago, and he's not a bad surgeon. I mean, most of us in this room could probably best him, but he's a decent surgeon. And so he went ahead and compared trab with mitomycin C to canaloplasty. Did 101 eyes randomized, 50 to canaloplasty, 51 MMC plus trab. Similar mean preoperative IOP use, IOP and medication use. Next. So what happened a year out? Okay, a year out, these are the pressures. Average 12.3, 13.4, not statistically significant. So as far as IOP reduction, trab with mitomycin C and canaloplasty, identical. And again, you gotta, realize that this was in iComed's hands. So certainly in my hands, I would not be able to get these results. So if iComed cannot get his average IOP of trab plus mitomycin C into that 10 that we all hear, oh, well, our trab, we got to do trab because it's got to be 8 to 10 millimeters of mercury. Not even iComed can average 10 millimeters of mercury. So canaloplasty in his hands was equivalent. Medication use, trab, canaloplasty, not statistically significant. Okay, next. How about comparison of vision? We are here to save our patient's vision, right? That's why we're doing this. We want to keep you from going blind. Well, what happens? Visual recovery was faster in the canaloplasty group. Well, that's not surprising. We all know that trabeculectomy, there's a long postoperative recovery process. But look at this. Best corrected visual acuity. They started out similar. It was better in the canaloplasty group. And next. All right. There's still this issue. Okay. Canaloplasty. The non-penetrating glaucoma surgeries are technically challenging. I'm not going to gloss over this. I'm not going to, paint a pretty picture or have you see through the FL41 rose-tinted glasses that you have to prescribe to your post-trab patients so that they get over the irritation. It is technically challenging. There's no question about that. Okay? That being said, iScience provides the most incredible support and training of any company that I have ever seen. I mean, they use cadaver eyes in the wet labs. Okay? Cadaver eyes. These aren't porcine eyes that some butcher, threw at them and said, here, use this. These are $500 per eye cadaver eyes with human anatomy for you to learn how to do it. And then the clinical specialists fly in, they're with you in the OR for the first half dozen cases, whatever you need. Okay? That support is there to get you past the learning curve because there is a learning curve. But that being said, I will tell you that if you're someone who just gets a kick out of surgery, okay, it's a fun surgery. When you first expose that trabeculodesmetic window and see aqueous percolating through, it's like the first time you were able to see the little individual red blood cells coursing through the conjunctival vessels. You just sit there and watch until somebody says, doctor, is something wrong? Because it's just so cool. It is technically challenging, but it is as effective as trabeculectomy. The studies that have been shown, not individual preference or belief system or dogma or mantra or doctrine, but actual studies support that it is as effective as trabeculectomy. And the reimbursement, finally, there's a code for it. Reimbursement this year, there is now a CPT code for canaloplasty. It reimburses between trabeculectomy without mitomycin and trabeculectomy with. So it's right in that range. Okay, next. So my hope is that in this talk, I've brought up some things that will get you thinking. Perhaps been a little controversial. I expect you'll disagree with at least some of my talk, if not all of it. But my goal here is to get you thinking. I don't expect that I'm going to have convinced everybody, but if I get you each to think about how you and your patients are working together to address this condition of glaucoma, then whether or not you actually start doing canaloplasty, it's fine. It matters not, so long as I've just kind of tweaked that and gotten you to think about your patients so that you can more effectively treat them however you choose to treat them. Thank you.
Thank you.